When Keith and when Meg asked me if I would do a legislative update, just talk to a few people, give a little legislative update at the annual meetings, what could possibly happen in legislation in healthcare in the United States? Not even the amazing Kreskin could have predicted the last 6 months in legislation. But I'm going to try to touch on some of the things that are happening really at the state level. Some of the things that are probably really important for you folks here. How many, a show of hands in this room, are you familiar with the certificate of need process? About half. I'm seeing about half. Okay, so the healthcare con. It's like McDonald's having to ask Burger King for permission to put a restaurant up. You have to ask your competitors. Well, you can skip that. You guys have seen my face already. First of all, before I get started, I want to thank Dr. Thomas Stratman. Dr. Stratman is a fellow at the Mercatus Center at the George Mason University who has done much of the research and certificate of need in the country. So any information you see out there likely came through this organization. They do a fantastic job at educating people around the country on the harms that these certificate of need laws can do to people. And he's agreed to let me use his information. But basically what a certificate of need does is it limits the ability, limits medical treatments. And it's essentially what we refer to as a competitor veto law. Again, if you want to put in a facility, you have to ask the facility down the street permission to put in the facility, and the state then grants that or doesn't grant that. So how did we get here? Back in 1964, New York passed the first certificate of need law, and I'll explain a little bit later as to why they did that, but basically they're trying to control competition with hopes of controlling cost, which is sort of the exact opposite of what we're trying to do in the free market movement. We're trying to improve competition, improve access, and their arguments were by limiting your choices, they could improve quality and limit the cost skyrocketing. So in 1974, they actually connected certificate of need laws to the Medicaid funding and coerced states to begin passing certificate of need laws in order to maintain their level of Medicaid funding. But they realized really quickly this was not having its intended purposes. So in 1987, the federal recommendation was actually repealed. But since then, despite the fact that every single presidential administration since President Reagan has given incentives and tried to encourage states to overturn their CON laws, we still have CON left in 35 states, and they're still being enforced to this day. So this is the lighter colors there are the states that have no CON legislation back in 1974. So this was when that first passed, and you can see very rapidly by 1980, only one state was left that did not have CON laws. But by 1990, when we started to try to push for the repeal, you can start to see it's very, very slow. So the uptake of the CON laws was very quick, but very slow to take these CONs back. Keep fast forwarding now to 2000. You're starting to see gradually chipping away at these, and now here we are today. Vermont was the last state just in the past year to overturn its certificate of need legislation. So just to kind of give you an idea of what sort of things are included in CONs, it varies from state to state, but medical office certificate of need is required in 2 states. So just to put up an office is required permission in 2 states. To buy an ultrasound machine, that's required permission in 4 states just to do something that simple. Cardiac catheterization, now we're starting to get up to some high numbers here. You need permission in 26 states to open up a cardiac catheterization lab. Ambulatory surgery center. Why isn't there a surgery center of Oklahoma on every street corner competing? Because it's limited in 27 states. That's why. Hospital beds. 28 states. I happen to practice in the largest city in the state of Florida that does not have a hospital. My practice is in Sarasota County, and our community, Northport, is now the largest, as I said, largest. We have 65,000 people. Our population actually passed the city of Sarasota in population. We've applied for certificate of need 3 times and been rejected. The city of Sarasota, that has, again, a lower population, they actually have 3 hospitals. So this is just kind of gives you an idea of the numbers of certificate of need laws by state. Oklahoma, nice, you're down near the bottom there with the number of things that you limit by CON. But some people may look at this as a red state versus blue state issue, but this is not a red state versus blue state issue. Vermont at the very top here has the most certificate of need requirements, and California down at the bottom is not a certificate of need state. So again, we talked about why we have the certificate of need. The certificate of need, the claims is that we're going to, by limiting the supply, we can control the costs. That makes no sense to most of us, but in legislative language, that somehow magically makes sense. The argument is you can't have 15 different open heart surgeries and have quality at all, or surgery facilities. You can't have quality at all of them. We need to consolidate them. And in theory, that sounds good, but in practicality, that's just not really worked out. The data doesn't really suggest that. And in the non-CON states, you're just not seeing those promises bear fruit. So, what it ends up becoming, or the CON's becoming a barrier to access. You have to apply for a letter of intent. You have to file a very expensive application. For just putting a couple room operating room, and you've got to drop an additional $45,000 just for the application for permission to even consider it. Then you have to hold public hearings, and you have to get then testimony, and you can now have appeals from your competitors. And even after your certificate of need might be approved, then there's an appellate process that goes on. And this drags on for months to years. This is a very expensive process. And the winners are always the hospitals in this. The hospitals are now beginning to establish monopolies. The costs are going up. They're controlling the entire environment. And the losers are innovators like Surgery Center of Oklahoma or any other facility that really want to step in and do a better service for a reduced price. And also the losers are all of us, all of the patients, all the self-funded plans that are responsible for paying these bills at these inflated costs. And so these are some major obstacles to things that are keeping this up. There are some great people out there working for this. I just wanted to show you there's a lot of cronyism going on in here. So I don't want to really get into the details of this graph, but just say that it makes a difference whether your CON application is approved or not based upon whether or not you made a financial contribution to a campaign. Try not to choke on your food. So what we've actually seen when you compare states that have CON laws versus states that don't have CON laws is you actually get improved access, improved rural access, improved urban access in the patients without, or the states without the CON laws. You actually see higher quality numbers. You see more competition. You actually see lower healthcare spending in those states and less corruption in the political process. So again, lots of people are litigating this. The CON was just heard in front of the Georgia Supreme Court just in the past couple weeks. So we hope to get a ruling in Georgia sometime soon. Many organizations like the Pacific Legal Foundation, Institute for Justice, Goldwater Institute has been huge in litigating these cases. And in fact, Goldwater was the one that just took the case in Georgia to the Supreme Court. So here's where my heart is in direct primary care. And this question actually came up this morning in our breakout session is, do you have concerns that direct primary care might be considered as an insurance product? And the short answer is absolutely. So the argument is, if you're charging a flat monthly fee for unlimited medical care, aren't you a risk-bearing entity, and shouldn't you be regulated as an insurance company? And if you sell one of those products, shouldn't you be licensed as an insurance agent? And in Florida, probably about 2010, we took this to the Florida Office of Insurance Regulation, took our practice model and said, what do you think? What does this look like to you? And they said, boy, this looks like insurance to us. And so, we took it upon ourselves to try to get some legislation to protect us in the state of Florida. We're still working on Florida, and I'll tell you about our story. One little plug I want to put in here, you see in the lower right-hand corner, DPC Frontier. Phil Eskew has done tremendous work across the country on all things DPC, but especially the legislative end of things. And if you haven't gone to his website, dpcfrontier.com, it is loaded with information. It also has a great mapper, which I'm going to show you, where you can find a direct primary care practice nearby nearby where you're located. But I can tell you that as of this past legislative session, we now have 23 states that have direct primary care protective legislation passed. So that's just in the past several years that many of these have come up, largely to the work of folks like Phil. I know Mike Champy's in the room, and he really almost single-handedly got the main legislation passed this year, and that was an awesome job, Mike. So I can share you a little bit about my experience down in Florida. We had trouble in 3 states big time this year, Florida, Georgia, and South Carolina. And it looks like the insurance companies are really starting to push back on this. They're started getting, seeing where things are going legislatively across the country. And the interesting thing in Florida, just to give you a sense of how much they wanted to put in how many roadblocks they wanted to put. Normally when a bill gets introduced, you might get 2 committee assignments if they want to really look hard into your bill. This year we got 7 committee assignments. So we got 3 committee assignments in the House and 4 committee assignments in the Senate, including appropriations. They actually tried to tie us to the state budget. So the bar was set really, really high this year. And we actually cleared every single committee unanimously. We had not one single person speak out against this, not in any committee, in any session, no public comment. We passed the House of Representatives 107-6, and it sat in the Senate until the last day of the legislative session, until one of the senators tacked on a poison amendment, and it died on the last day of the legislative session. So nobody could really figure out why this would happen, a bill that was just, there was a love fest for it. Why did it die? And in Florida, we have this neat little thing where you can actually pull up the lobbyists that registered to lobby on a particular bill. They don't say what position they're on the bill, but just that you've actually met with a lawmaker on a particular bill number. And much to my surprise, a little 1-page bill that says direct primary care is not health insurance had 200 registered lobbyists on the bill. Almost every single one of them were large health plans and large hospital corporations. Not one of those people made one single public comment in all 7 committee hearings. So, when I was on a call from Washington the other day, and I heard them say they were encouraged because the insurance company wasn't pushing back. The insurance company's pushing back. I promise you they're pushing back. But we saw similar pushbacks by the insurance industry in Georgia and South Carolina this year. I can tell you that for Florida, we have already had our bill introduced for the 2018 legislative session. It was actually one of the first bills filed for the 2018 session. So we'll make another run at it this year. We've got some ideas as to how to make it work. Some exciting stuff that's going on in Pennsylvania. We hope we can knock off Pennsylvania this year. Again, I think the insurance industry's got some pretty deep penetration up in that state, so hopefully we can get a little headway in there. So exciting to see those changes, but even more exciting is where we're seeing these practices pop up. And I'm going to go to Phil Eskew's DPC Frontier Mapper. Close to giving up on there. Okay. So there's a lot of dots on that. These are basically the direct primary care practices around the country that Phil knows of. And I can tell you that there are several databases out there, but Phil's is probably the most in-depth. I'm certain there are practices that are not on this map, but you can see it's saturated. Even in Florida, where we have no DPC protection, there are lots of DPC practices. And so I'm hoping that wave continues to spread across the country. I can tell you my organization, Docs for Patient Care Foundation, is putting on a direct primary care nuts and bolts CME seminar in October this year. We held one in Dallas last year. We had 275 physicians from 41 states attend that event. We're expecting an attendance of 300 this year, so hopefully we can keep that movement alive. The color coding on that is a green is a pure direct primary care practice. They do nothing but DPC memberships. The yellow, I believe that they were still trying to clarify exactly whether they met the DPC Frontier's definition of direct primary care, and the reds are hybrid practices where they take insurance and they do DPC as well. So those tend to be more corporate DPC clinics. Oh, what can we say about Washington? I thought about just putting a dumpster fire picture. Yeah, I don't even know where to begin on what. I probably don't want to spend a ton of time on Washington. I mean, I think everyone's sort of seen what's transpired. We had the repeal and replace that didn't go anywhere. We had the repeal and delay, which didn't go anywhere. We had the skinny repeal. Quite frankly, having read all of those bills, I didn't see where any of those things were actually going to have any meaningful impact on the problem. Not to mention that one of the things that's become very clear after my years of going to Washington is that Washington continues to think that they're the solution, but they're the problem, and they don't recognize that. But they think they're gonna legislate us out of this mess. And quite frankly, I think the best legislative efforts is really just to have them get more out of our way. So where do we go now that everything's sort of melted down? So you hear President Trump say that we're just going to go ahead and let it melt down and see what happens. I'm not sure that they're going to let that happen. We have a couple things. I think you're going to see some bipartisan things that are going to get through. I mean, we've got a debt ceiling issue that's coming up and they're going to have to reauthorize the CHIP program. But even if they did repeal Obamacare, we're still left with horrible regulatory environment for medical practice. I mean, we're left with HIPAA, we're left with MACRA, we're left with MIPS, we're with PQRS and quality metrics, and EMRs that don't work and meaningful use, and we can sit back and say, oh, it's the Democrats' fault and it's the Republicans' fault. They're all at fault. The regulatory environment for medical practices is absolutely horrible. So even with the repeal, and I met with Ben Carson up in Wilmington, Delaware. We had dinner, and I was explaining to him that just by flipping a D to an R, if you think you're going to solve healthcare's problems, you're wrong. Because some of the worst regulations to come out of Washington were passed by Republican House and Senate in MACRA. The MACRA, which replaced the horrible sustainable growth rate formula, has basically taken all of the horrible regulatory stuff that's in the Affordable Care Act and now made it a Republican initiative that's codified. And so there are lots of things that need to happen. And quite frankly, just everything's a mess there, and I'm not really sure how it's going to go. I can tell you a couple things that are encouraging from at least the direct primary care standpoint. There's a Primary Care Enhancement Act. This is a bipartisan bill. There is lots of speculation as to whether or not you can or cannot use health savings accounts to pay for direct primary care memberships. And the way CMS looks at it is not necessarily the same way that IRS looks at it. IRS looks at it as a health plan. The question is a membership, a healthcare service, and I think we could argue both sides of it. But it's safe to say that there definitely needs to be clarification between CMS and the Treasury Department. So I know that many people are working directly with the Treasury Department to try to get some sort of regulatory relief, and the feedback we're getting from HHS and from the Treasury Department is that this probably can't be done in a regulatory fashion. This probably needs to be done legislatively. So there is a bill basically that very clearly defines what direct primary care is and that you can use health savings accounts to pay for these services. There's another variation on healthcare reform that's probably DOA, but it's the Cassidy-Sessions bill. There is direct primary care favorable legislation included in that bill if that ever gets any traction, which I don't think it will. So again, we talked about there's lots of regulatory things that can happen in Washington, D.C. We all saw the stack of how high the Affordable Care Act language was, but the stack of how high the Affordable Care Act regulations are to the ceiling. Those can be changed. You can modify those. You can work on those. So whether or not they have the stomach to change them, that's a completely different story, but they absolutely can be modified. Executive orders, I don't want to get too deep into this. I can tell you that one executive order that was issued very early was basically very blanketly saying, do what you can to eliminate the pain from the Affordable Care Act. Okay, so what the IRS did was that when they looked at that, they said, okay, we're going to issue a ruling that says that if you've not had coverage and you leave the question on the tax form blank, we're not going to reject your tax forms. We're not going to send it back for that. But what they didn't do is go on to say, how would they treat that tax form then? Okay, we're not going to reject it. We're not going to audit you based on that. But will the default position of the IRS be that you had coverage or that you didn't have coverage? And will you or won't you be penalized? And so it's very unclear as to what that happens. But the IRS did, in fact, specifically state in writing that if you don't disclose that you didn't have health insurance, they're not going to do anything about it. But take that as it will. I really didn't plan to take an entire hour of your lunch. I know you guys want time to sort of digest a little bit about what you've heard this morning, but I did want to open it up to a little bit of conversation. I know we have plenty of time left. So just in general, you still up there want to throw around the boxes of microphones and see if anybody had any questions, comments.
Thank you very much for that. My name's Kyle Rickner. I'm a direct primary care physician, and I wondered, when looking at the regulatory environment and what's going on around the country, what do you see as the barriers to the proliferation of direct primary care?
In my experience, the Affordable Care Act individual mandate has probably been one of the biggest barriers to growth of direct primary care, at least certainly for my practice. Patients are having to choose between a plan they can't afford or coverage that they're going to be, or a coverage that they can't afford, or care that they are penalized if they purchase. And so that has definitely been a detriment to the growth of our practice. Regulatory-wise, the high deductible health plans just don't exist anymore. They're not compliant. There aren't enough direct primary care practices really to blanketly create these direct primary care programs. I know there's some creative ideas and creative solutions being crafted. And I was speaking with some folks earlier that are doing things. The healthcare sharing ministries have been an excellent resource to wrap around what we're doing to avoid penalties, and really have been a perfect marriage, but people don't understand them real well. And we're going to hear more about those today, so I'm actually looking forward to more people learning about those. But high deductible health plans, the affordable high deductible health plans don't exist. I'll tell you just sort of an amusing anecdote is one of my best referrers now for new patients is the Affordable Care Act-Navigator. These are the people that are responsible for signing people up for ACA compliant plans. So they'll sit down in their office and they'll walk them through the application process of getting their healthcare through healthcare.gov, and then they'll see what plans they're eligible for, and the patients will go, "What? It's how much for what deductible?" And then they hand them our brochure and say, "Have a nice day." Is there a question over there? Yes.
Yes, what can be done about anti-competition and antitrust activity? We have quite a bit of it in Utah that really squelches competition, especially in our area. A certain elephant in the room called Intermountain Healthcare has been trying to influence TPAs to not use the doctor's surgery center that I work for.
Yeah, that's probably a bigger question than I'm probably able to answer for you. Not our attorneys in the room. Yeah, as I said, there are lots of agencies, organizations out there that are starting to take up these fights when they're recognizing them. They need people that are willing to put themselves out there and become plaintiffs in these types of cases. And without somebody stepping forward and being the one to file the complaints and put your head on that chopping block, then you're going to keep having more of the same. And with the forced consolidation that we've had with the implementation of the Affordable Care Act and all these regulations, it's just getting worse. For the smaller practices to try to compete with these hospitals in this regulatory environment is darn near impossible. And I can tell you that our practice is probably the only independently owned and operated primary care practice in our region. Everybody's been bought up. And that, of course, hugely drives up the costs. So you'll have a cardiologist that's independently owned and operated one day, and you'll go in for an echocardiogram there, $150. They'll be acquired by the hospital. You go back to your same cardiologist in the same building with the same staff, the same exact test, but now the sign on the door has changed to XYZ hospital network, and it's now $650 for the same stuff. When you bundle in, you include the facility fees and the hospital increased, charge. So, that is driving up costs on a massive scale. So, where we see, like with the certificate of need, that we're going to go ahead and consolidate so that we can control costs, we're consolidating and raising costs, which is, again, what all of us in this room get, but in the real world as it's playing out, It doesn't work that way. So, now we're going to go ahead and we're going to start mandating price transparency, federally mandated or state mandated price transparency. You've got to put your charges out there. And this is starting to pop up in some other states. I think it's in North Carolina. It was this year that it passed. And, they were bragging about the cost savings. And I'm continuing to talk to you, but this is just general ones. They were bragging about an MRI that was charged by one facility $4,000 and the other facility was $3,000. And thank goodness to our mandatory price transparency that we saved the system $1,000. My MRI is $225. Okay? So that's my cost. That's not my charge. And so, for the difference, the patient could have flown from North Carolina down to Florida, stayed at the Ritz, had a five-star meal overlooking the Gulf of Mexico, flown home, and still saved the system $2,000. So these mandatory price transparencies, although I get where they're coming from with them, we're going to have the same thing. Everyone, posting their monopoly prices is probably not necessarily the solution.
Lee, over right here.
Yes.
Yeah, Lee. Related to the South Carolina and Georgia experience, and if somebody from South Carolina probably could Google this if they've got their machine up, but I guess there's a strategy out there that would utilize testing this with the state insurance commission if you kind of know they're friendly, using it as ammunition. And there was a practice in South Carolina, I think it was labeled it as concierge, but it was basically a DPC practice. And they sent a letter to the insurance commissioner detailing what they did and explaining the practice, getting their opinion on it. And it was very clear, unequivocally, that the insurance commissioner said, this is not insurance, it's nothing to do with insurance. But yet, like Georgia, they still struggle in the legislature. But I thought this was, it could certainly be ammunition, if you will, to get these kinds of things going kind of through the back door, so to speak. Do you know of that situation, and can you speak to it?
I was not familiar with that particular exchange in South Carolina. The challenge is, are you willing to put yourself out there and take that risk and go to the insurance commissioner and say, hey, this is what I'm doing, and do you like it or not?
I think there was some foreknowledge there, probably, that they may have known a little bit of a foregone conclusion, but there is a disconnect there. Some of the state insurance people think one way, the legislators, well, not the legislators, the lobbyists think another way, and so they steer the legislatures. And ours in Georgia has introduced 2 years ago, didn't get on the docket to vote on last year, or year before. Last year it was voted on. Unanimous, just like in Florida. Only 3 or 4 votes against, and it's set in committee, and the chair of the committee is in insurance industry in the private sector. So, those are tough.
Yeah, and it's tough because, although I sound like I'm anti-insurance, I'm not anti-insurance. I love insurance. I have homeowners insurance, I have car insurance. I hope I never use it, but I have it, and it's great. The insurance companies, I think, fear us for probably reasons they don't need to fear us. And in fact, I think, we stand to work very well together. And I think some people really get it, and they're designing plans around it, and hopefully they will pay attention and not keep fighting that fight. And not every state insurance commissioner is going to feel the same way on that, so you're going to take it to some and they're going to hate it. When I first took it to my state lawmakers, they said, wait a second, you're asking us to regulate you? Why would you do anything like that? Nobody said a word to you. And you could see what was happening in some of the other states and some of the pushback some of the original people were seeing on this, and you could just sort of see the writing on the wall and knew that if we wrote our own regulations, it would be much more favorable to us than if the insurance lobby came in and wrote those regulations. So, we tried to get out in front of that. So now this is probably our 4th attempt at getting this passed in Florida. And each time we end up having to make a little bit of a concession. And I can tell you that the feedback we're getting from the insurance lobby that they're willing to share to our faces is we don't want you double dipping. We want protection in there that says you're not going to charge the plan and the patient twice for the same service. And that's a fair request. But we had that in there. We still got it pushed back this year. So there's more to that than meets the eye.
Lee,
Yes.
thank you again for coming. For those of you in the room who were just meeting Lee Gross, he's a beacon for people all over the United States, myself included. So thank you again for coming.
Thank
Will
you.
you talk more specifically about your story and development of Epiphany Health, and time permitted, will you tell the story about the thyroid patient you and I collaborated on?
Sure. So we shared a little bit this morning, so maybe a little redundancy, but we started Epiphany Health in 2010. And in 2010, nobody had ever heard of direct primary care. But we in fact had an epiphany, and the epiphany came to us when a heating and air conditioning company owner came up to us and said, my insurance rates keep skyrocketing, and all my employees already see you. Why am I paying an insurance company to pay you? Why don't I just pay you directly? And I'll take out a catastrophic health insurance policy on them, and even if they hit that deductible and I pay it for them, we're still likely going to come out ahead. And my colleagues and I sat down and started running some numbers and doing the math and realized that we were doing everything wrong. The epiphany was, why are we insuring primary care? And we're not insuring gasoline for the car. We're not insuring light bulbs for the house. We don't insure lawn maintenance. Why are we insuring the most basic aspect of healthcare and funneling it through a health insurance product that's so inefficient? And so, as I shared this morning, when we bundle affordable stuff in with really expensive stuff, it makes the affordable stuff expensive. And so when we split that out, it became eye-opening for us. And we then said, well, what does a primary care doctor need to supplement or to support his or her practice of medicine? You need access to affordable labs, access to affordable imaging services, access to affordable physical therapy, just the non-big ticket stuff. And then we want to put prices on things. So originally we would go to the lab and say, okay, I'm going to send you 500 patients. And what you're going to do is you're going to bill each one of the 500 patients and try to collect from them the money from it. Or I can collect all the money right up front when I give them the lab slip, and you send me one bill for 500 patients. You no longer have collections for 500 people. You have collections for one. What pricing can you give me? And we saw 90 to 95% savings on the labs instantly. And so, just to give you a sense, the very first patient that I signed up had rheumatoid arthritis, and she went to see the rheumatologist, and the rheumatologist said, she can afford the rheumatologist appointment, but when he sent her to the lab quoted almost $2,000 for the blood work. And she called us up and she said, don't I get some sort of discount for this? I thought I got some arrangement for you. Got to rewrite it through our practice, and that $2,000 worth of labs came down to under $100. And so just that one savings alone, she can now continue to see her rheumatologist, plus she can have several more years of membership in our program. And so I shared briefly the story this morning. A friend of mine, Dr. Elena George, is an ear, nose, and throat surgeon in Atlanta, Georgia, and she does mission work down in the Caribbean island of Antigua. And she diagnosed a patient down there with thyroid cancer. And they couldn't find anywhere for her to have her surgery done in the Caribbean. And after I talked to her later, I guess they checked in with San Juan, and there was like almost $100,000 for her surgery in San Juan. So they connected this patient. Dr. George contacted Dr. Smith, and they evaluated the case. And after looking at it with the surgeon, said, we can do the surgery, but this patient's going to need 6 months of preoperative and postoperative care. He's going to need a workup, may need radiation. And so it's going to be a little bit more involved than just the surgery. And he called me up and said, Florida's a lot closer to the Caribbean than Oklahoma City. So maybe would you be willing to do it? So she got a medical visa, came to the United States, flew to Florida. We did her initial assessments, workup, did her imaging, all the blood work we needed to stage her, sent everything off to Oklahoma, worked with the surgeons and anesthesia to coordinate everything. And she flew off to Oklahoma City, had her surgery, came back, had her postoperative work done with us. Fortunately, everything was clear. She did fantastic. And the total 6 months, including her travel, her surgery, her assessments, her staging, everything I mentioned, including her medications, was under $10,000. So I don't know if you saw that the last Millman figures for a PPO for a family of 4 now costs almost $27,000 per year. And the average family of 4's out-of-pocket expenses for that plan is now $11,000. So that's per year. So what are we insuring when the insurance costs more than the catastrophic event itself? And so we see this now time and time, and I'm happy to report, Dr. Smith, I can't see you there, that we're now matching Keith's prices in an inpatient hospital facility in Florida. So we're now doing outpatient ambulatory surgery prices inpatient. So we're about to do our first total hip replacement, $25,000 bundled total hip. Now that may sound expensive, but that's probably $125,000 anywhere else. Includes the implant surgeon's facility fees, and also includes 1 week of inpatient rehabilitation. So lots of exciting stuff that we're doing down in Florida. It's been a long journey.
2 more questions. You got
Okay.
2 more.
Thank you, Lee. I'm Nick Pandelitis from York, Pennsylvania, and I just wanted to offer a different perspective on the CON, not that I support it at all, but perversely it just shows how messed up the system was, because the reality is that the third-party payer system drives essentially unlimited demand, and there is some logic to trying to control the supply side if there's no logic on the demand side. And the big problem in healthcare is what everybody in here is trying to fix, that there hasn't been an opportunity to compete on the basis of value. So absolutely these CON laws need to go away, but it has to be in an environment where there's an opportunity to compete on value. In our town, York, Pennsylvania, there were independent imaging centers and a surgery center, and what happened? The large nonprofit, which really means tax-exempt healthcare system, bought them out and raised up their prices. So again, there was some perverse logic behind it. Hopefully that reason for that logic goes away.
Yeah, I mean that's a great point on the supply side, because we see this also. I was talking with some folks from one of the health sharing ministries, and the challenge is what happens when the patient hits their share limit, or what happens when somebody hits their deductible. Well, you know what happens when somebody hits their deductible. The checkbook's open, sky's the limit. We're going to get everything done now. I hit my limit. I hit my $10,000 deductible. Now I'm going to get my hips, my knees, my cataracts. We're getting it all done this year. And so there's a big push to get everything in before the new year. And so how do you control when there's unlimited demand for services? And that's a fair conversation that we need to have.
Dr. Gross, I have a question that I don't understand, but I see all the biggest buildings in our town are due to the insurance companies, and yet it seems that they have the highest prices that they're paying out. Could you make sense of that for me?
No. Yeah, I'm not even going to get Keith going on the not-for-profits. All right, well, thank you very much.